We're going to be talking about therapeutic communication and the use of therapeutic communication techniques. Um, this is chapter 24 in your Potty Impaired book, pages 325 through pages 335. You also have ATI assignments, so please look at your legs for this chapter. We're going to talk about therapeutic communication technique, like I said earlier. But before we start specifically talking about therapeutic communication techniques, we're going to talk about lateral violence because it's real prevalent in the workplace today. It's also known as workplace bullying. The behaviors can include withholding information, gossiping, making snide comments or snide remarks, put down, ostracizing, displaying negative nonverbals, and these behaviors may escalate over time. New nurses are often the target of lateral violence. Low staff morale can lead to errors and it can affect patients' care and patient safety. There should be zero tolerance in the workplace for lateral violence, no exceptions. So in order to deal with bullying, you want to address it assertively, you want to report it to your nurse manager, and you want to keep documentation. When we look at bullying in the workplace, it's an offensive, abusive, intimidating, malicious, or insulting behavior. It can be abuse of power conducted by an individual or group against others, and it makes the recipient feel upset, threatened, humiliated, or vulnerable. And this undermines their self-confidence, which may cause them to suffer stress. Bullying is behaviors which generally are persistent, they're, systematic, and they're ongoing. Um, when we look at lateral violence, it's within nursing. It has been defined as nurse-to-nurse aggression. This violence can be manifested in verbal or nonverbal behaviors. The 10 most common form of lateral violence in nursing are nonverbal innuendos, um, verbal affront, any kind of undermining activities, whether they are withholding information, sabotage, there's a lot of infighting, scapegoating, and backbiting. Failure to respect privacy and broken confidence are all forms of lateral violence. And the last thing we're going to talk about in this category is disruptive behavior. Disruptive behavior is any behavior that interferes with effective communication among healthcare providers and negatively impacts performance and outcome. And this type of behavior is not supportive of a culture of safety. So disruptive behavior is also in that broad category of lateral violence. So we're going to spend the rest of our time talking about therapeutic communication. And when we talk about therapeutic communication, it's use of communication for the purpose of creating beneficial outcome for the client or for your patient. Therapeutic communication techniques are specific responses that encourage the expression of feelings and ideas and convey acceptance and respect. Active listening means being attentive to what the patient is saying, both verbal and nonverbal. So we're going to also talk about the use of shoulder setting, facing the patient, observe with an open posture, lean toward the patient, and establish and maintain eye contact. And above all, relax. So we're going to talk some more about that. When we talk about the characteristics of therapeutic communication, we know that it's purposeful and goal-directed. It has well-defined boundaries. It's client focused, it's non-judgmental, and it uses well-planned selected techniques. And we're going to be talking about some of those well-planned selected techniques. The goals of therapeutic communication is for self-discovery. You want clarification of thoughts, feelings, and action. And you want to look at exploration of new coping styles or behaviors. So all those are goals of therapeutic technique. Let's talk about the principles of therapeutic interaction. You want to plan to interview at an appropriate time. You want to plan that interview so you have adequate time to engage the patient. You want to ensure that there's privacy. You don't want to be talking with your patient in the midst of a group of other patients or other people. You want to ensure that there's some privacy. You want to establish guidelines for the therapeutic interaction. You want to provide for comfort. And you want to accept the client exactly as he or she is, okay? You want to meet the client where they are. Some principles of therapeutic interaction. You want to encourage spontaneity. You want to encourage the client to be spontaneous in their interaction with you and in their comments to you. You want to focus on the client and on the leads and clues presented. So you want to make sure you focus on the client, and whatever clues and lead they give you, you want to follow up on those clues and leads. You want to encourage the client to express their feelings. You want to encourage the expression of the feelings. And you want to be aware of your own feelings during the interaction, because it may lead you to some self-discovery about yourself. You want to use active listening. And I thought this cartoon was a good depiction of a person who doesn't have real defined active listening skills. When we talk about active listening, we're going to talk about solier. Setting, you want to set facing the client. You want to observe and have an open posture. You want to use your skills. You want to use the observation skills. You want to use your listening skills. You want to have an open posture. You want to lean toward the client when you're interacting so they'll know you're engaged in the conversation. You want to maintain eye contact. You don't want to be looking all around if the client is interacting with you, and you want to relax. One big thing we want to talk about in therapeutic communication is empathy. And empathy is the act of communicating to fellow human beings that we understand how they are feeling and what makes them feel that way. And so you want to make sure that you are able to communicate understanding. Okay. What are some obstacles to empathy? What keeps nurses from being empathetic? One obstacle to empathy is prejudice. Um, Prejudice is something that hinders us from being empathetic. Self-preoccupation. We're not really paying attention to what the client says. Excessive nervous talking. We're not listening because we are busy talking. Poor listening skills, poor assertive skills keep us from being empathetic, and low self-esteem are also obstacles to being empathetic. So how do we communicate empathy? Let's look at some general guidelines. Verbal techniques that we use. Reflection that is accurate and specific. We want to reflect on what the client says, but we want to be accurate in our reflection. And we want to respond using our own words and our own style of communicating. Okay? We want to paraphrase, make sure we understand what the client is saying. And those nonverbal techniques that communicate empathy is when we communicate warmth. We have to feel empathetic in order to communicate empathy, because if not, we're just showing a lack of genuineness. So we don't want to communicate empathy, try to communicate empathy if we're not feeling empathetic toward what the client is saying. So when do we want to communicate empathy? When the client is feeling hurt, or when they are confused, or when they are troubled about some things and troubled about what they're discussing with us, when they are anxious, when they may be feeling alienated, you want to communicate empathy. Doubtful of their own self-worth, when they're terrified, and when they are uncertain as to identity, you want to communicate empathy. So let's talk about 6 steps to communicating empathetically. 6 steps to communicating empathetically. You want to clear your head of distracting agendas. You don't want to be thinking about all kinds of stuff when you're trying to communicate empathy. You want to remind yourself to focus on the client, to focus on the speaker, to listen at what they are saying. You want to attend to your client's verbal and nonverbal message. I tell my students you want to pay attention to what the client is saying, how they're looking when they're saying, what kind of feelings they are saying, both verbally and non-verbally. What are the feelings they're trying to communicate to you? You want to ask yourself, what does this person want me to hear? What do they want me to hear? You want to convey an empathetic response. And then you want to check to see if your empathetic response was effective. Ask the patient if that's how you're feeling, or have I understood what you're saying so far? Let's practice. A client says, my child is retarded. I would like to have another child, but what if this child turns out to be retarded too? The first attempt at empathy, you might say, yeah, that's a big chance to take, isn't it? Getting pregnant, I mean. But look at this suggestive alternative. You have mixed feelings about having another child. On one hand, you like another child, but on the other hand, you're frightened that you may have another mentally impaired child. That's communicating empathy. And it takes practice. So let's practice some more. A client on Unit 2 says to you, I don't know what to do. My wife is a patient on the Unit 3. She just had a small stroke, and I don't know how to help her. Okay, so I want you to practice an empathetic response. I won't be able to hear you because we're not in class, but I want you to practice. I would say, it sounds like you are very concerned about your wife and how you can help her. That would be my response. This is another one. The patient says, I'm so glad I moved into the retirement village. Every day there is something new to do. There are always lots of things going on. I'm never bored. So the main difference between an empathetic response and a paraphrase is that the empathy serves primarily as a reflection on the client's feeling rather than focusing on the content of the communication. So let's look at how we would paraphrase that. To paraphrase this, you would say, so there are lots of activities to choose from, but the empathetic response focus on the client's feeling. You seem to love living there. A client says to you, this is another practice. I had a real scare today. My chest x-ray has a spot on it, and my doctor has called in a specialist to see what it is. I'm so worried because she told me that cancer can't be ruled out until I've had further tests. So how would you respond to that client with empathy? I would say that it sounds to me like you are worried that you could be diagnosed with cancer. That would be my empathetic response. What would be yours? So let's look at those empathy reminders from our practice and the things we said we need to do. This is this was developed by an associate professor at Harvard University, and I thought it was nice. So you want to make sure you have eye contact. This is the first indication that we have acknowledged an individual, and usually eye contact is the beginning of the interaction. We want to make sure our facial expression are usually a roadmap to how we are feeling. So we want to make sure we pay attention to the patient's facial expression. That may tell you more than what they're saying verbally. We want to make sure we have an open posture, because an open posture indicates that you are receptive, And it also helps to facilitate the patient's interaction with you. We want to look at our affect. Affect is the term for expressed emotion. So we want to try to identify or label the patient expressed emotion and listen to what the patient says with that perspective. It'll help us understand what the patient is trying to communicate with us. We also want to be attentive to the tone of voice, because our tone is an indicator of our real emotion. Okay? It's an indicator of our real emotion. You want to hear the whole person, hearing the whole person more than the words they say. Understand the context of the patient's expression and be non-judgmental in order to comprehend what they're saying. You want to pay attention to your own response, your feelings. We respond to others all the time, and know what you're conveying in your verbal and nonverbal responses. And you want to manage this part of your relationship professionally. Let's look at asking questions. When we ask questions, we want to keep the questions relevant. You want to avoid multiple questions. Ask your question one at a time and allow the patient time to answer the question before you move on. You want to avoid closed-ended questions. And those closed-ended questions are questions that give you yes, no response or one-word response, where the patient don't have an opportunity to expand on the issue. You want to make sure you give them an opportunity to expand on the issue. You want to make questions clear and concise. We talked about that, how we make questions clear and concise. You want to avoid asking why questions, because there is no answer for why questions. And you want to make sure that you summarize the main points before ending the interview. Do not end abruptly without summarizing your main points. So let's look at some specific therapeutic techniques. Nurses make observation by commenting on how the person looks, how they sound, and how they're acting. Stating observation often helps a patient communicate without the need for extensive questioning, focusing, or clarification. So you can certainly say, "You seem to be very anxious today." You are sharing an observation. We talked about empathy and how we share empathy and practice empathy. When nurses recognize that hope is essential for healing and learn to communicate a sense of hope to others, we want to be able to communicate a sense of hope. Appropriate encouragement, positive feedback are important in fostering hope and self-confidence and for helping people achieve their highest potential and to reach their goals. So you want to share hope. Humor. When we talk about humor, I think nurses don't use enough of humor. Humor is important, but often underused in nursing interaction. Humor is an important coping strategy that can reduce anxiety and promote positive feelings. Patients use humor to release tension. They use humor to cope with fears related to pain and suffering. They communicate and they communicate a fear, a need, or cope with an uncomfortable or embarrassing situation through the use of humor. I know my husband used humor all the time, so we have to get comfortable with using humor as well. When we talk about feelings or emotions, emotions are subjective feelings that result from one's thoughts and perception. Feelings are not right, wrong, good, or bad, although they can be pleasant or unpleasant. If an individual do not express feelings, stress and illness can worsen. So we want them to be comfortable in expressing their feelings as well. When we look at touch, touch is one of the most potent and personal forms of communication. It expresses concern or caring to establish a feeling of connection and to promote healing. Comfort touch, such as holding a hand, and is especially important for vulnerable patients who are experiencing severe illness, physical and emotional losses. Nurses need to be aware of the patient's nonverbal cues, and we have to ask permission before touching them to ensure that touch is an acceptable way to provide comfort. So we need to get permission beforehand. Silence also is a wonderful therapeutic technique because silence prompts some people to talk. It allows a patient to think and gain insight. Remaining silent demonstrates patience and a willingness to wait for a response when the other person is unable to reply quickly. So silence is something that we need to practice. So these are some therapeutic techniques. Let's talk about some other therapeutic techniques. Providing relevant information tells other people what they need or want to know so they are able to make decisions, they are able to experience less anxiety, feel safe and secure. It is also an integral aspect of health teaching, providing relevant information. How about clarify? Clarifying helps us to determine whether our message was understood accurately. Um, if we need to restate an unclear or ambiguous message to clarify, we need to be comfortable in doing that. In addition, ask the other person to rephrase it if you don't understand what they are saying, so that we are both on the same page. Focusing involves centering a conversation on key elements or concept of a message. Focusing on a key element or concept. If the conversation is vague or if the patient is rambling and begin to repeat themselves, focusing is a useful technique because it allows us to center on a key element. We talked a little about paraphrasing. Is restating another person's message more briefly using your own words. Through paraphrasing, you send feedback that lets a patient know that he or she is actively involved in a search for understanding. So it helps us to allow the patient to know that we understand what they're feeling and what they're saying. Validation is a technique that nurses use to recognize and acknowledge a person's thoughts, feelings, and needs. We want to validate what the person is saying. Patients and families know that they are being heard and taken seriously when we can validate um, their issues and understand what they're saying. Asking relevant questions. We need to ask relevant questions to seek the information we need for decision making. Asking only one question at a time and fully exploring one topic before we move to the next topic. Don't be so anxious that you ask multiple questions or the person feels like they're being interrogated. You want to ask one question at a time. Asking too many questions is sometimes dehumanizing to the patient. Summarizing is a concise review of the key aspect of the interaction. It brings a sense of satisfaction and closure to an individual conversation, and it's especially helpful during the termination phase of the nurse-patient relationship. And one other thing we want to discuss is self-disclosure. That's sharing your own personal experience and information about yourself that you reveal to another person. This is not therapy for a nurse. Rather, it shows a patient that the nurse understands his or her experiences and that they are not unique. Confrontation is also another therapeutic technique. When you confront someone in a therapeutic way, you help the other person become more aware of the inconsistencies in his or her feelings, attitude, belief, or behavior. So we've talked about some therapeutic techniques. Now let's talk about some non-therapeutic techniques. So if you're having a conversation with the patient and you kind of run back over what you said and what the patient said and how the patient responds, sometimes we find that some of our community techniques were non-therapeutic. Asking personal questions. Certain, when we look at the non-therapeutic technique, it often hinders um, our conversation or damage the professional relationship. So when we ask a lot of personal questions that are not relevant to a situation simply to satisfy your own curiosity, it's not appropriate for professional communication. Giving your own personal opinion. When a nurse gives a personal opinion, it takes decision making away from the other person and it inhibits spontaneity, it stalls problem solving, and it creates doubt in the patient. When we changing the subject, oh, we love to change the subject. Changing the subject when another person is trying to communicate his or her story is rude and it also shows a lack of empathy. It blocks further communication and the sender then withhold important information or fails to express their feelings openly when we change the subject. And we may change the subject because we're uncomfortable with the subject matter. Automatic responses. When we have those automatic stereotypical phrases that we say, uh, it often reflects poor judgment and it also threatens the nurse-patient relationship. When we say things like, it's going to be all right, I know how you're feeling, those kinds of automatic and stereotypical responses that we often use. Or we have that false reassurance. It's going to be all right. Everything is going to be all right. Don't worry. When a patient is reaching for understanding, false reassurance can discourage open communication. And when we look at sympathy, sympathy is concern, sorrow, or pity felt for another person. And patients usually don't want our sympathy. We can be empathetic, but they don't want our sympathy. They don't want us to feel sorry for them. Let's talk about some other non-therapeutic responses. Asking for explanation. Some nurses are tempted to ask patients why they believe, feel, or act in a certain way. Regardless of a patient's perception or motivation, asking why question causes resentment, insecurity, and mistrust. So we want to avoid asking those why questions. We want to and we don't want to impose our own attitude, values, or belief or moral standards on others while in a professional role. So we don't want to give our approval or disapproval. Other people have the right to be themselves and make their own decisions. Judgment, judgmental responses often contain such as should, ought to, good, bad, right, or wrong. So don't want to uh, you don't want to impose your own value by giving your approval or disapproval for what your client is saying. Defensive responses. Becoming defensive in the face of criticism implies that the other person has no right to an opinion. The sender concerns are ignored when the nurse focuses on the need for self-defense. They want to defend themselves or the healthcare team or others. So you want to avoid this defensive responses. When we talk about passive or aggressive responses, um, passive responses serve to avoid conflict or sidestep issues. They reflect feelings of sadness, depression, anxiety, powerlessness, or hopelessness. They, ref- aggressive response provoke confrontation at the other person's expense. They reflect feelings of anger, frustration, resentment, and stress. So we want to definitely avoid passive or aggressive responses. And you definitely want to avoid arguing with your patient. Challenging or arguing against perception denies that they are real or valid. So you don't want to argue with your patient as well. So we would certainly want to look at when our patients cannot speak clearly or we don't understand clearly what they are saying to us. We want to make sure we find ways that we can communicate effectively with our patient. Patients who are cognitive impairment, you want to make sure that you are communicating in such a way that if your patient has developmental delays or other type of delays, you want to communicate in such a way that they are able to understand what you are saying. Same thing with hearing impairment. You want to use those tools that will help you to be understood. Visual impairment, or if you're dealing with an unresponsive patient, you want to make sure that you continue to communicate with the patient and they understand what you are saying, that even if they're not responding to you. And if patients do not speak English, you want to communicate. You want to make sure you get an interpreter in so that patient will get clear instructions or is able to understand what you're communicating. So make sure you read chapter 24 in your book. Those pages that we went over. Make sure you do your ATI. If you have any questions, I'm in my office. Feel free to come by and we can certainly chat about anything that you don't understand. Thank you.